we're going to have a little update on hyperemesis. The reason I've decided to cover this is because I read a really interesting article and then followed a really interesting presentation on the fetal medicine webinars about hyperemesis, and it really made me rethink what I say to patients and how I manage this condition. So the link for the article is there, and Fetal Medicine Foundation have lots of really amazing free webinars. A lot of them are from world leaders in the field. They're free to access. Most of them are broken down into half-an-hour chunks, and I'd strongly recommend those. So most of this presentation is based on that lecture and on the paper that I've mentioned here. So I think it's really important that we first differentiate the difference between nausea and vomiting in pregnancy and hyperemesis gravidarum. So nausea and vomiting in pregnancy is essentially normal. It's experienced by 80% of women. They'll often have either minimal or no weight loss and be able to maintain adequate oral intake on most days. It can be managed with dietary and lifestyle changes. And symptoms would normally start to get better from around 14 weeks. And they should be able to complete their activities of daily living. So most people should be able to get on with their lives, go to work, and in the normal way. And if you contrast that to hyperemesis, this is experienced, it's difficult to say the exact numbers of women. We don't always see these women, they don't always present to services. But we think probably between 0.3 to 3.6% of women. To make that diagnosis, you're looking at somebody who's lost about 5% of their weight and have had an inadequate intake for the last days or weeks. These patients often require medical therapy and IV fluids, and unfortunately, the symptoms can persist until delivery. The signs that you'll see are electrolyte imbalance, particularly with low potassium due to the vomiting, and patients are often really very dehydrated by the time they've reached hospital. So the first myth that I'm going to bust is that hyperemesis is caused by beta-HCG. So this is something that I myself have told many patients, that it's the higher levels of beta-HCG that cause you to have hyperemesis. The beta-HCG levels, they rise throughout the first trimester, then they plateau, and then they actually decline in a typical pregnancy. And this is mirrored by the pattern of symptoms in hyperemesis, and so was thought to be one of the causal pathways. They both peak around 9 to 12 weeks, which is often when vomiting is worse. And you do get exaggerated symptoms in twin and molar pregnancies, which are linked to elevated beta-HCG levels. So it's a nice theory, and we can see that why that assumption had been made. But actually, when this has been studied, there have been really inconsistent findings in some pretty large-scale studies looking at beta-HCG levels and comparing these to people that have had either extreme nausea and vomiting in pregnancy and hyperemesis. What's quite interesting is there are strong familial associations in twin studies, and recently we've got new genetic techniques, and these have identified genes and receptors that are associated with nausea and vomiting in pregnancy and hyperemesis, particularly this GDF15. They've also identified the receptor GFRAL and then a IGF-BP7 genes, and these show strong correlation with people that experience hyperemesis in pregnancy. It's quite interestingly that GDF15 is also found to be elevated in patients with cancer and could explain some of the nausea, vomiting and cachexia that we see in patients with advanced cancers. It may be also that the placenta plays more of a role rather than just the fetus, which would potentially support why we see in patients with a molar pregnancy increased exaggerated hyperemesis symptoms, because it's essentially an overgrowth and overactivity of the placental tissue. And there's probably a role for progesterone and serotonin receptors as well. And I think, as we're all aware, it can present in patients that are having thyroid issues and H. pylori in pregnancy as well. So the next myth is that this hyperemesis that will stop after 12 weeks. So actually, lots of patients will have symptoms that ease from 12 weeks onwards, but 50% of women won't start to have resolving symptoms until 20 weeks. And about 10 to 20% of women will have persistent symptoms until they deliver. The next myth that we often hear is that it doesn't affect the mother. So it's just vomiting and we'll be able to manage that for you. So actually, when you look at the physical effects on the mother, they do get very dehydrated. They can get severe vitamin deficiencies, so even leading to Wernicke's encephalopathy. The electrolyte disturbance, if they are uncorrected or corrected too quickly, can cause cardiac issues and even seizures. Untreated thyrotoxicosis can also have cardiac implications. And for some patients, it's so severe that they actually end up with liver and renal dysfunction that persists throughout the pregnancy. Where they're very dehydrated and pregnant, there's a much higher risk of VTE in the form of thromboembolism. And just having protracted vomiting itself can lead to detached retina, rib fractures, esophageal tears, and even pneumothorax. And these have been reported in patients with severe hyperemesis. It's important to also consider the psychological impact on these women. So 37% of women decided not to go on to have any further children because they'd had such a bad experience with hyperemesis. A shocking 32% expressed suicidal ideation at the peak of their symptoms, and 18% went on to meet the DSM criteria for diagnosing PTSD because of how the impact the vomiting symptoms on their life. The next myth is that a baby is unaffected by hyperemesis, that the baby will get everything it needs from the mother and the baby will be fine. But actually, the worst period of hyperemesis often coincides with when the baby is undergoing rapid organogenesis and all of the baby's systems are developing. There have been associations, although not proven causality, with autistic spectrum disorder, ADHD, learning difficulties and delay, SGA, so small for gestational age, low birth weight, and having a smaller head circumference. There have even been reports of fetal losses, so miscarriage, with severe abnormalities in vitamin B and vitamin K deficiencies, which is why it's important that we address the nutritional needs of these women. And I think something that's very difficult to put a figure on is actually the number of women that go on to have a termination of pregnancy simply because of their hyperemesis symptoms. And this is reported as being between 3 and 4% in the UK, and potentially even up to 9% in the US in one study. The next important myth to address is that severe dehydration causes ketones to be present in the urine of women with hyperemesis. So this issue with ketones is something that's gotten into lots of guidelines and lots of assessment criteria for women. But it's important to realise that urinary ketones are produced when the body is in ketosis. Ketosis is a response to a low glucose or low carbohydrate availability, and it causes fat breakdown for energy production. And it's these ketone bodies are a byproduct of the fat breakdown. So it doesn't actually have anything to do particularly with the level of hydration. So in hyperemesis, you've got reduced oral intake, especially of glucose and carbohydrates, and that's what causes this process to happen. So the ketones are telling us that this patient has undergone a period of starvation rather than just dehydration, but the two can often coexist. So you may have somebody that is very dehydrated, but may be managing just about to get enough sugar on board so that they don't have ketones. And we shouldn't really be making decisions about treatment or admission just based on the ketone assessment. It should be a holistic assessment of the woman and her experience. So the management, if you've got a patient with nausea and vomiting of pregnancy or mild nausea, they will probably respond to lifestyle measures. So advising small, frequent meals, a high protein and carbohydrate diet, avoidance of spicy foods, and drinking fluid with electrolytes, so sports type drinks in between meals, and making sure they rest. And for somebody with mild nausea and vomiting of pregnancy, this may be enough to see them through. There is some evidence for complementary treatments, so we should be assessing the need for vitamin supplementation. Folic acid is advised for all women who are pregnant, but it may be that they need a higher dose of folic acid if they're not getting any in their diet, and we would give up to 5 milligrams. There is a role for ginger, so ginger, it's a little bit inconsistent, but it has been shown to help. Acupressure on the inner point of the wrist has shown to help in some studies, as has acupuncture. and nerve stimulation of the P6 point. So these are some complementary treatments that do have an evidence base. If you found somebody that actually these are not going to respond to complementary and lifestyle measures, we should move on to offer them pharmacological treatment. And this could be as an outpatient, or it could be that they need admitting. So with antiemetics, we would suggest initially starting with an antihistamine, so something like cyclizine. It's generally well tolerated when taken orally. If cyclizine is not effective, you can look at dopamine receptor antagonists, so prochlorperazine, which is stemetil, and then promethazine has a slightly sedating effect, which can be desirable if people are struggling to sleep due to their symptoms, and then metoclopramide as well. The last category of drugs from the antiemetics are the serotonin antagonists, so that's ondansetron. It's to be used second line because there have been studies with a very small increase in cleft lip and palate. So in our guidelines here at this hospital, we would recommend using it if other measures have been unsuccessful. If they're over 12 weeks, the cleft lip and palate are formed, and actually it would be more reasonable to use it, but we should be trying other measures first of all. There should be a note of caution that using metoclopramide should be second line because some people do get quite significant extrapyramidal side effects. If one drug isn't working, we should look at using drugs from different classes in combination, but do be careful rather than adding in 2 dopamine receptor antagonists because you're likely to increase the risk of side effects. And in very refractory cases, there's a role for steroid treatment, initially IV, and then moving on to oral prednisolone, and then tapering off to helpfully control their symptoms. The mainstay of treatment is then to replace fluids and replace electrolytes. So we often get a low potassium, you sometimes get a low sodium. You want to correct these slowly, so you don't want to rapidly correct a potassium level because it can lead to cardiac arrhythmia. And ideally, we want to correct the fluid and electrolytes before giving any vitamin supplementation or nutritional therapy to reduce the risk of Wernicke's encephalopathy. And that's the reason that we don't advise using dextrose. So dextrose, without correcting the thiamine deficiency, increases that risk of encephalopathy. So we do recommend if somebody has had reduced oil intake for a number of days and weeks, that we would certainly restart something like Pabrinex before giving them any dextrose. And we should consider oral routes where tolerated, so oral replacement with electrolyte drinks if they're able to tolerate them, rather than giving lots of potassium into a drip. The vitamin supplementation, oral thiamine is fine if they can tolerate it. Folic acid should be increased to 5 milligrams because it's unlikely that they'll be getting enough folic acid into their diet. We should consider IV Pabrinex, which is thiamine replacement and vitamin B complex replacement, if they're severe enough to be in hospital, and certainly if they've had multiple admissions. These patients often have coexisting reflux and gastritis symptoms, so something like omeprazole to help with acid suppression as well. So here in our hospital, we have a power plan. This is something that we have designed to cover the guidelines, to have the correct drugs from different classes and to encourage use of first line before moving on to second line medications. It's also got the regimes for hydrocortisone and prednisolone so that these are prescribed correctly if they're needed. And you can see at the bottom there that we've got the thiamine, folic acid and the Pabrinex dose as well, along with omeprazole. It's not shown here, but we've also got the initial fluid regime with a small amount of potassium in that first bag to help slowly correct the electrolyte disturbance that they may have. So there's quite a lot of research going on into hyperemesis. So future things that may come along the line are prediction, diagnosis and therapies based on these novel receptors that have been found, so GDF15, GFRAL and so on. It may be that either diagnostic tests or targeted therapies can be designed. What's quite interesting is it's mainly coming from the US, but there are quite high rates of self-medication with medicinal marijuana. That's being increasingly reported. We don't really know much about the efficacy and the safety, but there are trials ongoing to see if it is safe and if it is effective, because it's something that patients are often self-medicating for now. It would be great if we could have more patches and suppositories to aid outpatient measurements, so outpatient management, sorry, because lots of the drugs are either oral, which is difficult because they're vomiting. And then as soon as we get to needing IV or IM, that means that patient either needs to be in hospital or needs to be able to attend somewhere to have those injections. So if patches or suppositories were developed, it may be that there are more women that could be managed safely at home. There's an app based currently in the US, but it's about symptom tracking, so that you would be able to track and monitor symptoms, target interventions, and help people to manage their own symptoms with hyperemesis from a supportive way in the hospital, in a way that we are doing with conditions like gestational diabetes. So that may be something that comes in down the line. But actually, one of the most important things would be just having an international standardized definition. So it's very difficult to estimate how many women have hyperemesis when different countries and different researchers are using different terminology to define what hyperemesis is. So an international standard would be an important first step. So in summary, true hyperemesis gravidarum is not the same as nausea and vomiting in pregnancy. It's a debilitating condition which does have an associated fetal and maternal morbidity and should be treated carefully and seriously. Mild and moderate nausea and vomiting in pregnancy may respond to lifestyle measures and complementary measures, but it's unlikely that severe nausea and vomiting in pregnancy and hyperemesis will, so it should be taken seriously and we should offer treatment. There is a general reluctance to prescribe medications, probably coming more from our community colleagues, which should be addressed. We should be reassuring women that there are medicines that are safe and are used in pregnancy. An ideal resource that I direct women themselves to, and certainly our GP colleagues, is a website called BUMPS. So that's the best use of medicine in pregnancy, and it gives up-to-date information about the risks and the benefits of these medications. And we should move away from ketones for standalone decision making. They can be helpful, but actually we should be making clinical decisions based on the severity and deciding which patients need admission and which patients are ready to go home on a holistic assessment rather than a set number of ketones in the urine. So you'd be looking more at their mucous membranes. Are they dry? Are they thirsty? You know, what does their skin look like? And are they telling you, I can't drink anything without throwing up? So it's more of that sort of holistic clinical assessment. These are the references. So I've used the Royal College guideline, which is actually pretty out of date. I think it's 2015. So I don't know whether that's being looked at, but I was surprised actually how old that one was. And that, interestingly and tellingly, was the first hyperemesis guideline that they've done. The next few references are just more to do with the scientific background. So they're there if I can email them if anybody wants them.
As ever, I'll be really grateful of any feedback you have about what topics you might like covered in the future to help with your learning needs.